This conference will now be recorded.
Hello. Good morning, all of you. Hi, guys.
Good
Are you
morning,
there?
sir.
Can you hear me?
Yes, sir.
Pawan, how are you?
Fine, sir.
You said the classes are starting somewhere. Any news about it again?
No, sir.
Not within your, no light at the end of the tunnel. Still the life goes on like this. Okay, so already 100 people have arrived. I'll start today's class now. So the topic given to me is pediatric lymphomas. As all of you know, the malignancy is actually not so common in pediatrics, but still, if and when we come across such a situation, you should not be able to, you cannot afford to miss it. Okay, so what are lymphomas? Let us see today. So this is the concept map today. We are going to learn what are lymphomas and then the types of lymphomas. So when we classify them into varieties of Hodgkin's and non-Hodgkin's, the prevalence of each and the etiology, as far as we know, how they present and how you can diagnose them, what are the management principles, and with and without management, how do they affect the body, the prognosis. So these are the general concepts about it. So what is a lymphoma? As the name itself suggests, a cancer, any malignancy that starts in the lymphatic system, whether it is a lymphangitis, if it's the lymph ducts or actually lymph glands, wherever, whatever the lymphatic system is there, whether it is spleen, whatever it is. So in entire lymphatic system, whenever there is a malignancy, it's cancer, it is called as a lymphoma. So combining, including all both varieties, whatever it is, they are very third most common cancers in the children in the United States. They account for the 6% of overall childhood cancers. The most common malignancy in adolescents between 15 and 19 years. And as all of you know, broadly, there are two varieties. One is a Hodgkin's lymphoma. The second is a non-Hodgkin's lymphoma. So first we'll talk about the Hodgkin lymphoma. It's the neoplastic transformation of the lymphocytes, particularly in lymph nodes. And what determines it is a lymphoma, whether it is Hodgkin's, is the two characteristics. One is the presence of Reed-Sternberg cell. So the Reed-Sternberg cell is a histological. What is Reed-Sternberg? We'll see later. Sorry. And then spread in orderly fashion. For example, it's contiguous lymph nodes, one after the other, one after the other. So for example, if it starts in cervical nodes, it's spread to the supraclavicular. Nearest next group is anatomically which is nearest. That is sequentially it's going. So these two characteristics, one is histological, one is a clinical presentation, characteristic presentation. So these determine the Hodgkin's lymphoma. Then speaking of Hodgkin's, it is 6% of all Hodgkin's lymphomas. 5% of the cancers below 14, and 15% of persons between 15 and 19 years. And one problem in specificity is below 10 years, we don't see it at all much. So if at all a child comes with a suspected tumor under 10 years, Hodgkin's is not in the first line of treatment. There are so many classifications are there. The WHO classification, all of you are familiar now, actually. Be familiar with this. The WHO classification of Hodgkin's lymphoma. Just note that this is a very simplified and this is the most latest one. If you come across so many classifications, don't get confused. So as you can see, sorry. The WHO classification as for the 2000, as latest as 2000, broadly into two categories. One is classical Hodgkin's lymphoma, okay, and the second is non-Hodgkin's, nodular lymphocyte predominant HL, Hodgkin's lymphoma, classical nodular lymphocyte. So there is no further classification. We are not going to this nodular lymphocyte is itself is a category, and now subdivisions among it. But the classical H, but again is divided into four varieties. One is nodular sclerosis, classic Hodgkin's lymphoma. Second is lymphocyte rich, classic Hodgkin lymphoma. Mixed cellularity is the third one, and fourth is lymphocyte depleted. These four categories under classical. So remember, you keep coming across this. Sorry. Most of this classification is based on the histological appearance. Nodular sclerosis, lymphocyte predominant, mixed cellularity, lymphocyte depleted. These are the four categories under classical. So these are the histological features. If you see the nodular lymphocyte predominant, this is the one. Nodular lymphocyte predominant is this one. This category. Lymphocyte predominant is this category. Looks like that. Most of the lymphocytes, and these are the Reed-Sternberg cells. We'll go into that later on. So these are the, what are the Reed-Sternberg? We will see later on. The right classic Hodgkin lymphoma with nodular sclerosis. You can see the fibrosis on your right side. This part is all fibrosis and lymphocyte predominant, and with the Reed-Sternberg cells in between. These are the Reed-Sternberg cells. Mixed cellularity. These are lymphocytes, and there is other cells are also equally proportionate to there. In between, you can see that these Reed-Sternberg cells here and there. So these are the three categories actually. This is what I am telling you, the histological feature of a Reed-Sternberg cell. In examination also you can see cells with mirror imaging, actually as if you know, as if it is seeing in a mirror. See, eosinophilic inclusions in between the cells, actually inside the cells. They are of clonal origin, arises from the germinal centers of the B cells, B lymphocytes. Size is about 15 to 45 micrometers, multiple and multilobulated nuclei. So there's usually sometimes multiple nuclei may be there, usually mirror image cells of cells. Actually large cells you can see. This is a typical of a Reed-Sternberg cell. In the diagram also easy to draw in the examinations. Always try diagrams. So exact etiology, nobody knows actually. We can only think of a risk factors. See, all these malignancies are genetically based, and there is actually preponderance or cervical types. I'm not going into the genetics of all these things. It's much beyond the undergraduate level. So what your concern is, there are certain factors make them susceptible. What are they? Certain viral infections, especially the Epstein-Barr virus, HIV virus, cytomegalovirus, somehow they play with the genetics, genes of the babies, and they alter the tumorigenesis of these cells. So after the infection of the Epstein-Barr virus, there is a tendency to develop a Hodgkin's lymphoma subsequently. Yes, the immune system actually one thing which prevents any abnormalities, but if the immune system is weak, either because of the inherited conditions like iatrogenic, either because of the medication or whatever it is, some disease causing immunodeficiency, or certain drugs, especially the drugs used after organ transplant. You give a kidney transplant and give some supply, because to prevent the graft versus host reaction, you give some immunosuppressants. But the adverse effect of these immunosuppressants is development of these malignancies like Hodgkin's lymphoma. Age factors, especially common in teens and adults. As I said, below 10 years, we don't see Hodgkin's lymphoma. And 35 years and adults aged 55 years or older, actually, as old age prevalence, also Hodgkin's lymphoma is common. Adolescence is common. Family history. Suppose if one person is having either the brothers or sisters or a person with Hodgkin lymphoma, other lymphomas are maybe having other lymphoma, he can develop Hodgkin lymphoma. So maximum we know the risk factors: viral infections, immune system, specific age factors, and family history. These four factors, if you write, the risk factors of the Hodgkin lymphoma. That's enough. Now, clinical presentation. How do they present to us? As all of you know, any either Hodgkin's or non-Hodgkin's lymphoma, lymphadenopathy, because especially cervical, supraclavicular, the most common sites. And how are they? They're painless. Painless. Inflammatory lymphadenitis most often are painful. So contrary to that, these are the painless swelling of the lymph nodes. They are not tender even if you touch them. No. And typically is a rubbery consistency. They are firm and rubbery consistency is typical of a Hodgkin's lymphoma. Because there is lymphoid tissue in the spleen and liver, there may be hepatosplenomegaly. Cough, dyspnea, hypoxia, especially the mediastinal lymph nodes are enlarged, they can cause compression of the respiratory tubes. So in that way, they can produce cough, breathlessness, because of the continuous compression hypoxia. When there is a pleural and pericardial effusion, because adjacently there is an inflammation is there, like in malignancy is developing, there can be pleural effusions or pericardial effusion and subsequent symptomatology related to that. When the hepatocellular dysfunction, when the swelling, because the infiltration becomes so much, the liver function fails. Hepatocellular dysfunction can manifest in the form of various liver failure signs. If it is bone marrow that is infiltrated, naturally there can be all the pancytopenia, anemia, we can, depending upon the cell line that is affected, anemia, neutropenia, thrombocytopenia. And rarely, less commonly, it is the skin that is involved, pruritus, and if the central nervous system involved, lethargy, anorexia, and pain. Pain may be anyway. So these are the common symptomatology with Hodgkin's. Now, specifically, that's what you must be. I want to draw your attention to what is called as the B symptoms. What are these B symptoms? Number 1, fever. Number 2, drenching night sweats. Number 3, loss of weight more than 10%. All these three put together is called as a B symptoms. So what are these? Why is importance is they are present in 1/4 of the cases of patients and presents in significance effect on the prognosis. There is a bad prognosis actually. So look for these symptoms: fever, drenching night sweats, and weight loss more than 10%. Weight over 6 months of age. Within 6 months, if a child loses weight of 10%, that's a significant. So look for the B symptoms always. Now, when the involvement is beyond the lymphatic system or the usual lymph nodes and lymphangitis, so if the spleen, liver, bone marrow, lung, and CNS, these are the organs that may be affected. And extra lymphatic, actually CNS involvement is less common with Hodgkin's than with the non-Hodgkin's. That's one thing. But these other organs may be involved. So corresponding manifestation may be there. The liver, spleen, liver is, as I already told, liver is involved, makes liver failure. Bone marrow is involved. They can see pancytopenias like that. Lung is involved. Respiratory symptoms like that. CNS involved. CNS symptoms. Some symptoms of immediate, there is a red alert symptoms or emergency presentation is acute infections and superior venical obstruction, SVC obstruction. Superior venical obstruction produces facial edema, increased JVP, and sudden increase of breathlessness. This is a very, very emergency. You have to attend to this. Otherwise, child may present land in a ICU. So these are called the emergency presentations. Not so common, but they can be present. You must be aware of the red cells. Now, staging. Staging criteria, actually based on what you do, these are the criteria you take into this. What is the number of lymph nodes involved? Whether these lymph nodes are on one side or both sides of the diaphragm. So if you divide the body into two halves, upper and lower halves, dividing being the diaphragm, whether they are on both sides or only one side. Whether the disease has spread to the other systems, as I said, bone marrow, spleen, and liver are involved. I said if it is involved or it is confined to the only lymph nodes. So that factor depends. And any of these situations, common A and B system. What is A is with symptoms and B is asymptomatic. There is with symptoms, A is without symptoms. The only swelling is there, that's all. So A and B, for A, where the involved, these lymph nodes only involved, but there is symptoms. So there is a lymph node stage B and B. So we'll see that how you document it in a systematic way. So this is the latest one. There are so many classifications are there. the Lugano classification of them all. This is 2014 one. So still there are limitations of the Lugano because it's not pediatric Hodgkin's is not taken into consideration in spite of that. So it is mostly based on the adult manifestations, but still this is the one actually our Nelson Pediatrics gives, Lugano classification of Hodgkin lymphoma. Based on this, there is 4 stages, 1, 2, 3, 4. Stage 1, what does it mean? Only one lymph node or a group, one group is involved, and single or extra nodal is there, but only one lesion, one area, without nodal involvement, only that area. For example, only spleen is involved, like that, something like that. So all these come under category 1. Second stage is 2 or more nodal groups. That means either axillary or a femoral, something like whatever it is, but not on the femoral, not like that. Actually, axillary and cervical, but on the same side of diaphragm. This is important. They are on the same side of the diaphragm. Or nodal extent with a limited contiguous extranodal involvement. That means there is nodes are involved and a little mediastinum also, because the mediastinal lymph nodes are actually the compression of the trachea or some actually bronchi. Some, that means the respiratory system is also involved. So limited, that much. That is stage 2. Stage 3 is nodes on both sides. As I said, the axillary and femoral. So there is both either side of the diaphragm. There is not either, it's both sides. So with the spleen involvement or with spleen involvement, there is a cervical lymph nodes involved, but spleen is also affected. So that is actually considered as stage 3. Stage 4 is additional non-contiguous extra lymphatic involvement. So it's not cervical lymph node alone, but there is liver and spleen also involved. So extra lymphatic system or CNS is involved, like that. So it is a stage 4. So again, I told you the B symptoms. What are the B symptoms? Presence of fever more than 38 degrees centigrade or 100.4 on 3 consecutive days. Drenching night sweats, then 2. And third is unexplained loss of weight of more than 10% in a period of 6 months preceding admission. So these 3 are called as a B symptoms. So if the B symptoms are noted, all these are stage 1. A. Without B symptoms, it is stage A. With B symptoms, it is stage B. Again, stage 2 also can be A without B symptoms. With B symptoms, it is B, stage B. A, B. Like that, each one can be A and B. So this is common for all these things. B means B symptoms. There are these symptomatology are there. A means these symptoms are not there. That is called the B symptoms. That's the diagrammatic explanation. This is diagrammatic explanation on Arbor classification. This is the older one actually, comparatively this is 2000 or something, but it is a very familiar one. Almost characteristically there are not much of differences, subtle difference only. That's why we can use this. Just be aware of the on Arbor classification. This is common for both Hodgkin and non-Hodgkins, both. So stage 1 is only one area above diaphragm. You can see there is a diagram. Stage 2 is above diaphragm, but in 2 areas, axillary and cervical. Stage 3, both sides of the diaphragm involved. So femoral or spleen and liver, all these things. Stage 4 is multi-system involvement. Liver, spleen, and there is a pelvis involved, and the lymph nodes are also involved. And again, at each stage, you can have either A type means there's no B symptoms, B type means B symptoms, fever, night sweats, and weight loss. As I said, how much it is already categorization I already given you. Now, what are the diagnostic methods? Yes, you got a clinical suspicion. Lymph nodes are there. There is a swelling, and actually they're rubbery. But the true diagnosis is always biopsy, only excision biopsy and incision biopsy. So please remember, finite biopsy aspiration syndrome is no. Is usually cannot remove the large enough sample. Pathologist cannot make a diagnosis and can classify and type it. So it should be excisional or incisional. These two are only correct. Most important step is this is a diagnosis, because we have to stage it, and depending upon the stage you have to plan the therapy, whether to surgery or radiation or chemotherapy, whatever it is, you have to decide on this book. So biopsy very important for therapeutic point of view. Now, what is the diagnosis? Actually, you can take any chest X-ray. The additional investigations which may help you. One is a chest X-ray, show whether swollen lymph nodes are there. whether they are on either side or other signs of the chest involvement is there or not. You can see. You can take a chest CT or pelvis depending upon your extent of this thing. MRI can be available whenever it is a soft tissue involvement is there in the, especially the stage 4 and all these things. There is a positron emissions tomography, especially special type fluorodeoxyglucose, FDG PET it's called as. Is very diagnostic categorization. This is may have to do lumbar puncture for CSF cytology if it is CNS involvement is suspected only in those cases. And bone marrow biopsy, usually when there is a B symptoms are there, always go for bone marrow also in extent, and especially in stage 3 and 4 also bone marrow biopsy is indicated. These are the investigations you are advised. You can see that mediastinum involvement. This is large lymph nodal mass in the mediastinum in the extending with this mid zones. So, what is the treatment? What is the management of the lymphoma? If it is a localized disease, for example, in stage 1A or 2A, whatever it is, even the symptom, 2 also in both sides, but A means no B symptoms. So, predominantly you can manage with radiation only. That's the radiation therapy. But patients with B symptoms, such as well as in the stage 3 and 4, you have to go for the chemotherapy because the radiation alone will not help. Either radiation with chemotherapy or chemotherapy alone. That depends upon. So, coming to chemotherapy, there are so many combinations are there. As for undergraduates concerned, the COP and ABVD is enough. What is COP is a mnemonic for that. Cyclophosphamide. O is oncovin. Actually, trade name is oncovin. It is nothing but vincristine. P is procarbazine and another P is prednisolone. So the dosage regimen exactly undergraduates we are not asking. So just remember COP regimen. What is C, what is O, what is P, you have to able to tell that. The other regimen which was more prominent is ABVD. Adriamycin, also second, the trade name of doxorubicin, nothing but. B for bleomycin, B vinblastine, not vincristine. Please remember V is vinblastine and dacarbazine. So this is additionally prednisolone may be and cyclophosphamide and etoposide may be added actually there subsequent to that. So basically it's ABVD. And now there is a monoclonal antibody that we know biological therapies are the commonest is the rituximab. Especially it interferes with the NF kappa B pathway. And one of the latest one is the brentuximab vedotin. Brentuximab vedotin is a combination of antibody plus drugs. This is a combination therapy. Brentuximab vedotin. Rituximab is the only monoclonal therapy. Brentuximab is a combination with the antibody and drug conjugated. So these are the combination therapies that are available, chemotherapies with the Hodgkin's lymphoma. So with all the therapy, what are the prognosis? The best prognosis is a lymphocyte predominant type. We have seen so many varieties now. Lymphocyte predominant has got a better prognosis. There is a good immunity. Worst prognosis with lymphocyte depleted or the tumor size is very big. Advanced stage, already stage 4 or 3B, actually whatever it is. And the presence of B symptoms are always a bad prognostic sign. Okay, so these are the prognosis about the Hodgkin's lymphoma. Now we go to the non-Hodgkin's lymphoma. It's a neoplastic transformation of either B cell or T cell, both lineage of lymphatic cells. So non-Hodgkin's lymphoma actually is a much more common than Hodgkin's lymphoma. It is the second most common malignancy between the ages of 15 and 35. And 60% of the lymphomas, childhood lymphomas, it is NHL, non-Hodgkin lymphoma. And all those, because if you see subsequently, you can see that it's a broadly divided into high grade and low grade types actually, depending upon the severity. And unfortunately, if at all the non-Hodgkin lymphoma occurs in pediatrics, it is always a high grade type. It is a very rapidly growing type and bad prognostic type. Slightly double preponderance, male preponderance, almost double or more than double in male children. And factors increased incidence with the especially severe combined immunodeficiency, HIV infection, Epstein-Barr virus, post-T cell depleted bone marrow transfusion. After this, once we purposely deplete the bone T cells to prevent the GVHD, growing graft versus host reaction. In such patients, they may develop. And post-solid organ transplant, also kidney transplant or heart lung transplant or such cases also, there is a chances of developing non-Hodgkin lymphoma are very high. You must be very, very cautious. Next, so other risk factors, as I already told you, HIV, Epstein-Barr virus, especially Burkitt type of lymphoma, Helicobacter pylori infection. It is commonly with the extranodal tissue generating lymphoma, especially what is called as MALT is an acronym for the mucosa associated lymphoid tissue. So MALT type of lymphomas develop especially after H. pylori infections. Then human T-cell leukemia, lymphoma virus, HTLV virus infection, and after hepatitis C virus infection. These are the predisposing factors for the non-Hodgkin's lymphoma. Then the classification, non-Hodgkin lymphoma is much more complicatedly. Several books have given separately. Latest one is WHO real classification. It's called as a WHO classification, but it is a little very, very difficult to follow undergraduate level. So I have simplified into for you. Just remember this classification is enough. Non-Hodgkin lymphoma, broadly you can divide it into B cell or T cell. This is simple because it can develop in either cell. So again, B cell classification, there are two varieties. One is Burkitt lymphoma, second is DLBCL, that is diffuse large B cell lymphoma, diffuse large cell B cell lymphoma, DLBCL. So these are two varieties, 1, 2 under B category. Under T cell also there are two varieties. One is lymphomatous lymphoma, second is anaplastic large cell lymphoma. Lymphomatous lymphoma and anaplastic large cell lymphoma. Just remember these four names, that's all. So if you give this diagram, that's more than enough if you draw classification of NHL. Now, we'll see what are the characteristics of this ward. Depending upon this, though, Burkitt lymphoma is most common variety, is 40% of the narcolepsy. As I said, it is a B cell origin and characterized by abdominal tumor and head and neck tumor, especially all of you know the Waldeyer ring actually, and this around the neck. So involvement of bone marrow and CNS are common with this. This is the characteristic of a type, first one, Burkitt lymphoma. The second one I told you again from B cell is a diffuse large B cell. It accounts for about the 20% of the B cell origin. Again, it's a nodal, abdomen, bone, and mediastinal mass, less commonly CNS. That is a diffuse B large cell lymphomas. Now the two, sorry, this has to be 4 actually. So 3 and 4 are from the T cell lymphomas. The 3 is lymphomatous lymphoma. It accounts for the 30% of the NHL, and most of the T cell are lymphomatous lymphoma. Common manifestation intrathoracic and mediastinal, supradiaphragmatic as always. Involvement of bone marrow and CNS is very common. The last variety is 10% of NHL. Sorry, it is only 30. What is remaining is only 20%. Sorry, 20% of the T cell origin and primary cutaneous manifestation. This is skin manifestations are more common, and sometimes systemic diseases like fever, weight loss are common. Dissemination to viscera and mediastinum is anaplastic, and prognosis is also bad for this. Fortunately, it is the least common of all the varieties is anaplastic large cell lymphomas. So these are the 4 categories under non-Hodgkin lymphomas, you remember. Now, how do they manifest? Put together all common things. Actually, all varieties put together. Commonest is the lymphadenopathy, superior vena cava syndrome, because when the compression of the superior vena cava, especially mediastinum involved, and also compression of the airways causes breathlessness. The mass in the liver or spleen or intestines, whatever it is, lymph nodes produces abdominal mass, and they may compress the intestine, produces interstitial obstruction or intersusception. There may be ascites, nasal stuffiness, earache, tonsil enlargement, bone involvement, especially local involvement or swelling of the bones, acute paraplegia and secondary to CNS and spinal cord compressions, and last is tumor lysis syndrome, especially when you start treating them, this tumor lysis syndrome, because suddenly the most large number of getting apoptized actually. Because when they are destroyed, what happens is the uric acid is released from them. So this will produce a uric acid excess and actually various electrolyte disturbances causing hypophosphatemia, tumor lysis syndrome. And remember, NHL is 10 to 20% around the localized ones. CNS involvement is very common within non-Hodgkin lymphoma, and HIV positive patients especially are they prone for NH, this CNS involvement post HIV. So these are the clinical manifestations of the non-Hodgkin lymphoma. So you can see that here tumor of the oral cavity here and large lymphoma in the face and bone is also involved here with the jawbone. So this is typical of a Burkitt's lymphoma. So St. Jude staging. This is also very familiar class staging. So what they do is actually it's not a apart from your Arbor staging is common for all this thing. St. Jude's only tells you only about the severity, how severe it is actually, how acute it is. So basically there are two varieties. One is low risk, second is high risk lymphoma. These are the advanced ones. So the first category is localized. It is called as localized when it is a single tumor, extranodal or a nodal single anatomic area and not involving the mediastinum or abdomen. That is the stage 1. Stage 2 is again single tumor but with the regional node involvement or a primary GI, 2 or more tumors. Well, all these things again come under localized area only. Whereas stage 3 and 4 is systemic involvement actually. Primarily intrathoracic, extensive primary intra-abdominal, paraspinal and epidural tumors, 2 or more nodal or extranodal areas, and all these with CNS and bone marrow involvement also makes it a stage 4. So stage 1 and 2 are low risk, stage 3 and 4 are high risk according to St. Jude. So if you remember on Arbor, that is okay, but St. Jude, if you write, you will be giving more marks because it's related to the severity. The only low risk is 1 and 2, high risk is 3 and 4. That's all. If you remember, that is enough actually. So what are the diagnostic modalities we have? We do tissue biopsy, either flow cytometry or karyotyping for the bone, for the risk factors. Complete blood counts, the bone marrow involvement are not there. Serum electrolytes and calcium, phosphorus, uric acid, especially if you are suspecting a tumor lysis, tumor lysis syndrome, TLS. So liver functions and renal functions is depending upon the organ involvement. Bone marrow aspiration biopsy, as I said, all stage 3 and 4 you require these things. CSF examination, if your CNS is involved or not. Chest X-ray shows how much mediastinum's involvement is there. CT scan, same thing, whether it is head, neck, chest, abdomen, depending upon the area of involvement. Positron emitting tomography and bone scans wherever it is necessary. These are the diagnostic modalities we do. Coming to the treatment, again here also chemotherapy is the most basic line, and commonest is CHOP. What is CHOP? Again, mnemonic for this: cyclophosphamide, hydroxyadriamycin, oncovin is nothing but vincristine, P for prednisolone. So CHOP is the commonest one. Sometimes we have to use them intrathecally also. Not all medicines, certain medicines can be given intrathecally. Now, if the CNS lymphoma or superior venocoma syndrome or paraplegia or such things are there, you have to go for radiation also, in addition to CHOP. So whenever there are relapses, again they are controlled with them, they may have to go for bone marrow transplantation. So compatible bone marrow transplantation. And again, biologicals like rituximab, especially patients who are expressing CD20 antigen on their greater amount, they are susceptible for this monoclonal antibody therapy with rituximab. Supportive therapy, in addition to that, granulocyte colony forming units, actually colony stimulating factor, sometimes prophylaxis, and when there is severe neutropenia you have to use, and also tumor lysis syndrome is there. Antibiotic prophylaxis for second infections whenever this blood and platelet transfusion depending upon the bone marrow involvement. Allopurinol, especially if the TLS is there, tumor lysis syndrome, to reduce the uric acid concentrations, and parenteral nutrition when the patient is not able to take oral. Treatment of complications, you can see new infections, mucositis, pancytopenia, electrolyte disturbance, growth retardation, cardiac toxicity, gonadal toxicity leading infertility, and secondary malignancies. Again, because when I said one lymphoma is there, they may develop Hodgkin also in addition to this. Actually, all these things you have to keep in mind. So these complications, if they're present, you have to manage that. So what is the prognosis? Compared to other, prognosis is good with the radiation therapy and chemotherapy. For this, 90 to 100% now with the modern methodology, non-Hodgkin lymphoma is very good prognosis. With advanced disease also, they are telling now 60 to 95% survival rates actually. So compared to other diseases, non-Hodgkin lymphoma is a better prognosis with a good treatment. So that's all. Thank you very much. So this they will upload into system, and those of you who can want to access, you can access. Thank you very much. That's all. Okay.